So hi, everybody. Thanks again for coming back to our Zoomcast series today. I am delighted. We have a real treat on our hands. We have Dr. Inga Lennes, who is the Senior Vice President of the Mass General Physician Organization. Inga's role really is to run all of ambulatory for the Mass General ambulatory program, which is a vast program, not only primary care, but all the subspecialties as well. So welcome, Inga. And why don't you tell us a little bit about yourself?
Sure. Well, thank you. Hello to everyone out there. It's a pleasure to be here. So yes, I am first and foremost a lung cancer doctor. That's where I got my start. I work in the thoracic oncology group, and I'm a medical oncologist. I've been at Mass General for just over 10 years. And I trained in the combined program at Mass General in Dana-Farber and have been here ever since. I've worked in administration really since that time. I kind of knew even back then that I was really interested in making the care that we deliver better. And I started off in quality and safety. So did some extra training in quality and safety, and then was the director of quality and safety for the Cancer Center for almost 7 years, and really got a taste for administration there, and had a lot of fun working with our really multidisciplinary groups. So pharmacy and nursing and inpatient, and really was a great way to learn all about hospital operations because I had to have sort of a finger in a lot of different areas. And then also was exposed to hospital administration through the Center for Quality and Safety and other groups that sort of were wove through the hospital. And then a few years ago, this job opportunity came around as a Senior Vice President for Practice Improvement and Patient Experience for the hospital and the physicians organization. And I'd really loved the opportunity to move into this space. It was an education going from thinking about cancer to thinking about everybody in the ambulatory. The ambulatory enterprise at Mass General is really big. So many people don't realize this, but we see in normal times 12,000 patients a day in our ambulatory clinics. And we have over 250 practices in 55 different locations. So the world of ambulatory is vast, and 97% of our patient contact is done in ambulatory. If you add up all the touches to all the different patients that we have contact with during a year, 97% of those contacts are on ambulatory and in outpatient settings. So it's a big part of patients' experience, and I'm really proud to work at Mass General and take the lessons that I learned in the Cancer Center to the whole place. So.
Perfect. So you played a pivotal role in the MGH response to COVID-19 through your leadership on this organization called HICS, which stands for HICS, Hospital Incident Command System. And HICS basically governs everything. Peter Slavin, the president of the hospital, and Tim Ferris, the CEO of the physician organization, basically turn over the operational leadership to this HICS command structure. It's very military-like in its hierarchy, and we all follow the HICS leadership memos like religion, and we wait for our instructions every day about, okay, what does HICS say, and what do we do? So tell us about HICS, and tell us what your role is in there, and how it all got activated at the beginning of the COVID process.
Sure. So I had to learn a lot about HICS structure too. As you mentioned, I'm what they call the operational lead for ambulatory. So HICS structure, a hospital incident command structure, is the same as an ICS or an incident command structure that exists in almost every large corporation in the world. And definitely there's a HICS structure in every single medical arena. I didn't know that. The construct comes from FEMA, the Federal Emergency Response System or administration, and it's very regimented. You mentioned the military, but every single incident command center has the exact same leaders. So there's the command leadership, which in our HICS command, Ann Prestipino is our HICS commander, And there's a group of people that support her in that role. And one of those things are, for instance, communication. So Peggy Slaisman is the head of the communications for the command role. Under the command role, there are always 5 different committees. So there's an operations structure, a logistics structure, a planning structure, a finance and administration structure, and then also a communication structure. So those are the 5 groups that always report to the incident commander. My role is there are 2 different groups in the operations section. There's an inpatient operations section and an outpatient. So I'm the leader of the outpatient operations section, which is one of those 5 sections that reports to the incident commander. And there's a group called the planners. The planners are also report in that command structure. So Paul Bittinger is the director of emergency preparedness, works in the emergency room, and is also our co-incident commander and the partners incident commander. And so in this process, I didn't know anything about incident command really until this started. And I read a lot of FEMA documentation about it. The incident command in emergency situations does take control of the organization. And it's always very regimented along these lines. So this is temporary. The incident command structure does not stay in place once we have passed through the emergency. And part of the important part of transitioning from regular operations, or I should say from incident command operations to regular operations, is the skillful transition between incident command structure and regular operations. And I would say that is the part of the emergency response that we're in right now, is thinking about the recovery and that transition from our incident command structure back to regular operations.
So when this all broke, just to give the audience a sense of like the enormous responsibility of your role in the ambulatory is, you know, we think of, oh, Mass General all of a sudden converted all of these inpatient beds to COVID-19 beds, and we all kind of had to rework our own roles, like from being an oncologist to being an inpatient COVID-19 doctor or responding clinician. But the vast majority of patients that we interact with are actually not inpatient, right? The vast majority are ambulatory patients. And so there has to be a connectivity for a patient walking around in Boston or New England who has to come to the Mass General. They had to interact with the Mass General and then be to determine whether they needed to be an inpatient or not. And basically, that was your responsibility. How does the outside world interact with Mass General Hospital? So how did you set all this up in such a short period of time?
Well, with lots of help, I will say that is that there are at least 19 different work streams that have come up under, you know, the work just in the ambulatory arena, and we connect with the partners work streams or the Mass General Brigham health streams as well. So one of the first things that we started to think about was, if you start with a patient journey, I always like to think of things from how the patient experiences this. And the first thing we thought about are, what are our communications? So if I'm at home and I need to be in contact with my provider at Mass General, or I think I need to be seen, how am I going to get to that person? So one of the first things that was set up jointly throughout all of our systems was an integrated nurse hotline. So at the partners level, they said we need to put together a nurse hotline so that anyone who has a COVID question can access us rapidly. So that was one of the first things that we thought about. We also created communications that went out through Patient Gateway about what COVID was, what the symptoms were, and how to access our COVID care. The next thing that we thought about in rapid succession is, if someone suspected that they had coronavirus, how would we see them and keep them safe and keep our providers safe? So with appropriate protective equipment. So the RIC clinics were born. RIC clinics stand for respiratory illness clinics. And those are the clinics that were first stood up to be able to see patients in a way that they were in a different location and not filtering through our ambulatory universe and exposing other patients or our providers in those places. So those were the first orders of business, is finding a way to have patients be able to access us very quickly, get the information that they need about testing and treatment for COVID, and then having the place where the high-risk patients could be seen and we could start to test. As testing has evolved and we have opened up more and more testing, as kits become available and lab capacity was created for testing, it became clear that patients who were just tested may need to then come back to access ambulatory care, right? Like our oncology patients who test positive for COVID, but they still need oncology treatment. And so the next evolution was, okay, we've designed the initial diagnosis place. What are we going to do to create a place that's safe for them to come back and access care, even when they might still be shedding virus? And that is the RAC clinics, the routine ambulatory care of COVID positive patients. And the RAC clinic started in the Cancer Center. I think the Cancer Center can be very proud of the work that it did to create that. But it's accessed by people who come from all over the place that need to, OB patients, ortho patients, post-op patients, primary care patients that need to access that space because they're still COVID positive. And RAC clinics are now being built in other places. So Chelsea, Newton Wellesley, the RAC clinic that was born at MGH now is being replicated across partners and in other places as well. And I always tell people the thing that we built just now is the shelf life for any decision is about a week. So we'll see what we have to do next. And one of the things that has been really fantastic about this experience is seeing how fast and how quickly we can make change. And it's been awe-inspiring. You know, I work in normal conditions, making change with people on the order of, you know, months or, you know, and that's fast, months to years for, you know, changes. We stood up new ambulatory areas in the matter of days and retrained people, rebuilt, like physically built new spaces.
Yes. Yes.
And I think that is one of the most incredible things I have ever seen, is to watch our buildings and grounds and our, you know, the folks that work in materials management. You know, I say we need to source pulse oxes for these new RICS clinics. I need 70 pulse ox machines. And there's a team of people that deployed instantly to all of the clinics that weren't being used. And we had 70 pulse oxes, like, you know, or I need a new door cut through this wall so that we can have a separate entrance and exit for patients with COVID. And then magically the door was cut into the building. Like these are the types of things that happened that I tried to take pictures along the way of some of these things that happened because they were so astounding to me as they were happening.
I think one of the myths that's out there is that, you know, MGH is this COVID hospital, but really COVID exists throughout the entire community. Every single hospital is having to try and figure out how to separate the COVID positive patients from the COVID negative patients. And yet, you know, MGH has this wonderful program that you're a leader of that can make these things happen almost overnight in terms of the new pathways that are developed. So it's really been remarkable to see. As you were in the beginning of this, what were some of the decisions that kept you up at night? Like, what were some of those things that you were just lying in bed going, oh my God, how am I going to make this decision? Or maybe a decision you made that, I don't know if this is the right thing, but you don't have to give me the exact decisions, but what were the types of things that kept you up?
Yeah. Well, I think anything where we were going to ask a clinician to work in a COVID setting. So as we began to expand the RICS clinics or the RACS clinics, you know, I don't take those decisions lightly. So when we create a patient care area and we're putting in the infection control measures to make sure that it was safe, I think those are the nights where I couldn't go to sleep, where I was saying, have we done every single thing that we possibly could? And the level of detail in some of these areas, you know, having specific valets meet patients in the parking lot, having cards that are specific colors given to patients so that they're routed, you know, in a way that cohorts COVID positive patients in one area and COVID negative patients in another, or COVID unknown in a different one. This is the level of detail, even to the point where we have specific people that are washing the buttons on the elevators for every elevator that's used by someone who might have COVID, and they're washing them in between every single use, like, and that we document that. That level of detail is the things that we kept going back over and over again and said, have we crossed every T and dotted every I, so that if we are going to ask our clinicians to do this work, that we can go to bed at night feeling like we have done every single possible thing to make sure that they are safe, and that every other patient that we are seeing who can't stay home is also safe. And I think that's something that I worried about, I have to say. And then you get kind of used to making decisions. The other thing I wanted to say about this is that in the beginning, you know, we never make big decisions without lots of discussion and lots of people weighing in.
Right.
And one thing that I personally had to get used to really quickly is saying, okay, we have talked enough. This is the decision. And it's uncomfortable because that's not usually how we make any decisions around here.
Right.
But I would say personally, that's one thing that I have had to get over pretty fast. And then I've also realized that it's better to just to be clear and to make a decision, and then to collect the data and be honest with yourself about whether that was a good decision or a bad decision, and then regroup, than to hem and haw and not make a decision, because then there's nothing to react against. There's no thing that you can say that you did that then worked or didn't work if you just stay in a hazy gray zone. So,
right.
And that's not always our nature. So I had to get better at that really fast.
No, and you did. I think probably some of your, I think back to some of the quality and safety projects that you had in the cancer center. For instance, documenting every single way that the minute the doctor hits enter in terms of the chemo order, how it actually has to get into the patient. I remember you were one of the first people to do that for us, and actually published on that whole process of documenting it, and realizing that we had, for each different place that we had in the cancer center, we maybe had different ways that an order actually got translated into drug getting into somebody's vein, and we had to smooth that all out and make that uniform. So as you think about ambulatory care in the future, in this new post-COVID world that we now live in, what do you think is here to stay? And what are the lessons that you've learned through this crisis that you're going to apply when things get back to semi-normal in another 2 months, let's say?
Yeah. Well, here's the things I hope stay is, I think that, you know, before this started, less than 1% of our visits were done using virtual care. And last I looked, over 85% of our ambulatory touches were being done using virtual care. So some combination of phone and computer visits. And so one of the things I definitely hope stays is reimbursement for virtual care, and the operations to integrate virtual care into our regular operations. I think that over the course of the past month or so, I've seen physicians and APPs become much more comfortable doing video visits. And I think patients also, we had to bring patients along that journey with us as well. They had to be more comfortable doing this, and the whole world has gotten more comfortable with the Zoom and, you know, with the video interfaces. So that's definitely one thing I hope stays. The other thing is that some of the things that we struggled with prior to COVID, I think one thing that sometimes these emergencies help to do is they burn off all of the subterfuge and things that aren't important, yeah. Right? And we get a clear look at some of the things that are really, really important. And so my hope is that as we restart ambulatory operations, is that we can move even quicker towards those end goals that we had in mind and we were looking at, but they weren't quite that clear. So what would those be? Like, you know, patients should be able to access us really seamlessly. Every patient, you know, or almost every patient should have a gateway account, and we should be really good at interacting electronically with patients, and we should answer the phone within 30 seconds for every single call. Like, those are some of the things that we feel really strongly about. I think that also we should communicate more with patients. I've heard from patients who really appreciate getting some of the communications that our team has sent through Gateway to the special populations like cancer, just giving them information. And I think that there's an opportunity to continue to do that and to be more tightly connected with our patients and not think of the patient interaction as an in-person event. It's a longitudinal relationship that we will caretake using a variety of means, including virtual communication. So I hope that those things stay. I also think that we will be much better at distributing care. So the old model of, you know, you have to come to one place always to get your care. I think I've seen this in the cancer center is that, you know, you might get a lab draw here, you might get an infusion there, your care might be based with a doctor team in this other location, and we should all be able to work together. That's happening in every single department. So the departments that have distributed networks are thinking about this. And I have to say there's concentric circles. In other places, you know, we may have more people thinking about how to work together even across partners. So, you know, units that are really staffed, you know, thinking really closely about how to align with Newton Wellesley or North Shore to make it as efficient as possible. So I'm really hopeful about those changes and the acceleration we're going to see for patients.
I am too. I think this is going to be one of the most exciting times for medical innovation in the delivery of care that we've seen in the last 20 years. So I am incredibly hopeful. And I'm thankful for people like you at the Mass General. You do a terrific job. And thanks for taking time out to talk to us today.
My pleasure. Be well, everybody. Stay safe.